Hi, this is Gordon Christensen. I understand we have people listening tonight from far away from where I'm located. I'm in Provo, Utah, USA. You're looking at the Wasatch Mountains on that view. We're going to be discussing tonight some very pertinent topics. Basically, you can see the title, and as a prosthodontist, I've been grafting extraction sites for several decades. I find it to be probably one of the most advantageous procedures I could possibly conceive, not only previous to an implant, but also when I'm doing a fixed partial denture and need to preserve the ridge. I thank Kerr for setting this up and for allowing me the freedom to talk about any product we want to. And you're going to find numerous products here that will infer that there are many ways to do grafting of extraction sites. Just a little preface before I get really started here. You're going to see again, the Wasatch Mountains. That large mountain that you're looking at is Mount Timpanogos. I'm in the building that you see right there. I'm sitting right about where my arrow is. And this is a center that has been around now since 1980. We have had a product evaluation group since 1976. And that is called now Clinicians Report. It used to be called Clinical Research Associates for many, many years. We changed the name just a couple of years ago. We had in our May issue of Clinicians Report, which many of you receive, a quite detailed report on the various grafting types of materials that there are and which was working best. So you may want to look that up. That was May 2010, Volume 3, Issue 5 of Clinicians Report. That will summarize in written form or in on the internet the information, much of which I'll be talking about tonight. Now there are some websites for you. The one at the bottom will get Clinicians Report, and that's how you would find information that I've been talking or will be talking about on this presentation. The top one leads you to videos and courses, many of which will relate to the same topic. The implant videos are directly related. Some of the oral surgery ones are as well. I'm going to try to be extremely pragmatic tonight. Most of you know me. Some of you don't know me. Although I am a prosthodontist and have been for many, many years, I do Good. Am I back with you? It sounds like it is. Any problem, Trung? Okay, good. I don't know why we disconnected there. Thank you. We evaluate about 700 new products per year. One of the Kerr products I'm going to talk about tonight, we evaluated about 15 years ago. And therefore, this is no new product. Now, keeping going, let's take a look. Why are we doing this? Why are we preserving the ridge? I'm going to give you some very interesting pictures to observe for just a minute. You won't like them. Take a look at that one. This is a 17-year-old boy. Somebody took out a tooth shortly after it came in. It was broken. The tooth was taken out, and as you observe the ridge in this area, some of you do implants. I've been doing implant surgery for 25 years. I would have a little fear and trepidation trying to put an implant in that area. I think you would too. I need 6 millimeters of bone from the cursor there to the cursor here, and there's no bone. Would not it have been appropriate had this dentist placed some material in there, and then I would have some space in order to be able to place an implant? A typical 4 millimeter diameter implant. Okay, let's see. Okay, I'm all right. I'm trying to point, and am I pointing, Trump? We're trying to get all this console. No, why not? I have show cursor here, Is it showing now? Okay, good, good. Somehow we had a disconnect there. If you observe this area, then let's repeat that. From where the cursor is now to where the cursor is now, that's about what amount of bone I would need for a 4 millimeter diameter implant. I could certainly place a small mini implant of 1.8, 2.4, 2.9, but they're not that well proven in a single tooth situation. In other words, this dentist fouled up, who did not place something in this young man when that tooth was extracted. Now here's one where a tooth was taken out and the ridge was grafted and it healed. And there's plenty of room to go ahead and do whatever we want to do in that kind of a situation. There were the tooth preparations that I made, and subsequently the impression, and as you might expect, the dies. Now that ridge area is such that we can easily place a pontic in it and have little or no difficulty with the aesthetic result. Okay, and looking further, you can see there's a zirconia-based fixed partial denture, which basically looks like a tooth. That's what we're talking about relative to use of grafting before placement of a fixed partial denture. There was no reason in that particular one to place an implant. This is an utter disaster. I hit this about, it has not been very long ago, probably 3 or 4 months ago. Someone had taken a tooth out and had inadvertently taken half his head with it, as you can see. This is about a 60-year-old person. He's an airline pilot just getting ready to retire, getting newly married, and this fixed partial denture goes clear around to the other side. What in the world am I going to do? Somebody wanted to graft it. What are you going to graft in? His whole leg into that area? This is a complete disaster where some dentist, I imagine, whether he was hung over or what, I have no idea, broke off a good sizable chunk of the maxilla. What do you think I did there? I did not graft. They wanted to graft, but the chances of that taking would be very remote. We therefore did a fixed partial denture, and it was just seated just a few days ago with great success. He only smiles about to where my cursor is, and there's no problem. But that's not what we want to do. Look at the bone that's been lost in that area. That's the last view you just saw. Probably the same dentist left that root tip. This man's had some fairly low-level dentistry. Nothing that we want to scream home about. That much bone resorption is not where we're going to graft without taking bone from. Where would you take bone from if I want to graft into that area? That would be bone from the chin or the ramus, the tuberosity. You have to be shavings from somewhere else, or it would be from the iliac crest. Nobody wants to go through that. You hear that in all the implant meetings. I'm a diplomat in a couple of the implant academies, and every meeting I attend I find these exotic grafting procedures going on. In the meantime, as I speak a good bit, I find in groups, say of 1,000, I may find 2 or 3 who've had any graft such as that in a year. Therefore, we're into something that they talk about a lot but not done much. There's that case. Is that pathetic or not? That's the epitome of what we're talking about tonight. There were the preps and basically build-ups, and we had to do it with a fixed partial denture. Okay, what are we going to graft with? Let's take a look at that. You may know these words completely. I never know where to aim a presentation like this because I don't even know where you are, and you can't see me. You're everywhere across the earth, and these words may be very, very much in your vocabulary. They may not. I don't know why they call them this. It makes no sense to me at all, but these are the words. Autogenous means the patient's own bone, and from the sites that I previously stated. That's an autogenous graft, so stick that in your vocabulary if you don't have it. Now, what's an allograft? Now, graft tends to be, I don't know how you memorize, but I tend to memorize with similar things. If I say allograft, it sounds like it's a graft of bone. It is. It's human cadaver bone, and there are a couple of major types. demineralized freeze-dried, which has been the most commonly used one, and mineralized freeze-dried. They're different, and they're certainly used in our report that I just mentioned to you, May 2010 Clinicians Report. We give you many brand names on those. Now, what's an alloplast? That's synthetic. That's the one I'm going to demonstrate shortly relative to the Kerr product. That is either a ceramic or a polymer or who knows what. There are all kinds of things that have been used as an allograft. One of the most popular forms right now is a xenograft, and where in the world they got that word, I have no idea. It had nothing to do with the creation of it. And that is some animal, that's cow bone, or one of the grafts we use is cow skin, bovine in other words, or porcine, which would be pig, but this is a xenograft. I hope you've got those words now. Any one of those could be used in a socket graft, which is our primary orientation tonight. We're not going to go into extensive grafting. We're talking about socket grafts. Autogenous, most of you won't do that for a socket because you have to carve bone off somewhere, and that's not a pleasant procedure for the patient. You have another site from which you've taken this bone, and it hurts. In fact, if you carve a big chunk off the hip, it will take 9 months to heal, whereas the mouth heals in a few weeks. It's not a pleasant thing, but it's being used. The allograft is easily used, but expensive. You get a little tiny bit of it. I'll give you some prices in a minute. A little tiny bit of it for $100. There are those who would say, I don't know whether I want somebody else's rear end in my mouth. I don't know. So that has a little connotation of worry, not to me, but it certainly does to some patients who will get on the internet and find, ooh, somebody else's bone is going in my mouth. But it's used very commonly. Now, how about alloplast? Alloplast, I have no problem with at all. These are synthetic materials, so we're going to look at one heavily tonight. I shouldn't say tonight, because some of you are somewhere where it's not tonight, it's morning. I'll call it this presentation. So these alloplasts, I have no problem with biocompatibility if they've been tested well, and some of them resorb, some of them do not resorb. We'll look at some of them in just a few minutes. Then the xenograft, as we give you some brand names, you'll recognize them. Those are easily used too, and there are plenty of cows running around you can hack a piece of bone off from. Looking further, here's some most popular grafting materials. How do I know that? That was done recently in Clinicians Report, where we surveyed the types of grafts that were used, allograft, alloplast, and xenograft. Obviously, autogenous is the patient's own. And these came out as the most popular. And what does most popular mean? It means something. Some say, well, who cares about popularity? I care. You don't continue to use things if they don't work. If I was using Bioplant, which we're going to talk about tonight, and I had it fail 2 or 3 times, I'm looking for something else. I have not had that experience. We've placed that hundreds of times with very, very minimal challenge that we'll get into. All of these are very popular. Now this allograft, remember what that meant. Remember what allograft meant. That means human cadaver bone. So where are we? If they've carved that off some cadaver, you've either got Zimmer with pure os or BioHorizons with mineros, and both are extremely popular. In the alloplast area, Bioplant, the Kerr product, most popular. And how about xenograft? You need to look seriously at this foundation. I'm not going to talk a whole lot about it tonight. This is cow skin. Cow skin. And it comes from Japan, Jimarita. It has been around now since the 60s for placement over 3rd-degree burn wounds, skin wounds, where there is no epithelium. On goes this cow skin, and it grows back a form of epithelium. Some smart dude decided they would try it in bony defects, and lo and behold, unbelievably, it grows bone quite rapidly. And within 10 weeks, I can place an implant in such a situation if it had all 4 walls of the socket and an apical orientation that was sealed without any perforation into the sinus or the infraalveolar canal. Foundation, look at it. And BioOs is one of the very, very popular ones from OsteoHealth. It's a xenograft. Cows and cows. Cow skin, cow bone. Okay, and I hope you've got all that, and I hope I wasn't too rudimentary. There are some membranes that can be used that are relatively inexpensive. Now, the product we're going to show you tonight, you don't need much of a membrane on. But you may know these. These two are from Zimmer, Colla Plug, Colla Tape. These are just collagen. They dissolve or resorb fairly rapidly and can be placed over the top of some of these materials that require a membrane. A membrane's another pain because for you, because you're paying money for it. I would prefer not to have to do that. Gel foam, almost everybody here has gel foam. And gel foam is simply used and turns to mush as you put it over the top, a couple of sutures over it, and that holds some of these in very nicely. We'll look at it momentarily. Long-lasting membranes. Now, some of them, when we put the grafting in, require a membrane that is basically going to last a long time. Some of them forever. I used for quite a few years polytetrafluoroethylene. It's a white material, looks like a chunk of plastic, ridiculously obscenely expensive compared to what it looks like it ought to be. Looks like you've cut it off a plastic bag. But in the meantime, non-resorbable. We would leave that in for 4 weeks, 6 weeks over the top of a site we had grafted, and then without even anesthetic, jerk the little piece of white plastic out. And it did not have epithelium growing. The epithelium grows in very rapidly, and that's one of the real challenges. If the product does require some form of membrane and you do not put one over it, you have a particular problem. Fibrous tissue invades at about 500 microns a day, and bone creeps at 50 microns per day. In other words, what we find is that the fibrous tissue will grow in much faster than the bone can fill the hole. A membrane prevents the faster growing soft tissue from invading. But membranes you need to know about, or I don't use them much with socket grafting, but somebody's going to say, oh, you have to use one. Wrong. I'm going to take you back one slide. These are inexpensive. Colla Plug, Colla Tape, gel foam, relatively inexpensive, like $10 you're looking at right here. 10 US dollars, and that allows me to cover it over relatively well without an expensive $100 piece of stuff. So there are some membranes for you. How? Let's look for a minute now. And I'm going to take you through a typical case. An atraumatic extraction. Some of you don't know what I'm talking about there. How do we take a tooth out without creating the disaster you saw a few slides ago? There are instruments some of you have and many of you don't have. I'll give you some brand names in a minute and show you some of those. An atraumatic extraction means even though the tooth is off at the bone line, which you see fairly often, or it's a multi-rooted tooth with a root off at the bone line, I was taught many years ago just to take off the buccal bone. That was stupid. If I took off the buccal bone, I had a defect for life, like some of the cases I've shown you. I'd like to take the tooth out and leave all of the bone. In other words, I have 4 walls: facial, lingual, mesial, distal. Atraumatic extraction is mandatory for a simple grafting technique. Now, some of these will have radiolucency, which is obviously some kind of fibrous tissue. So you need to debride that quite well. Go in with a surgical scooper outer debridement instrument and peel out that soft tissue. If it is a cystic area, go in with a small round burr and decorticate that bone because it has cortical bone on it if it's a cystic situation. And with your excavator, your little spoon, go in and scoop it out. If it's solid rock in there, you better take a burr and decorticate it, puncture some holes in it. Seldom do I do that, but occasionally there's a big cyst around the end of the tooth. Fill the socket with something. We're going into it in a minute. You've just seen lots of possibilities. Now, do I need a membrane? Yes or no? Some yes, some no. I'm going to show you no membrane tonight. Then suture it. Can you get primary closure on every one of these? Absolutely not. Usually not. I can often split the epithelium and put a thin layer over it, but that's a problem, and some of you don't want to do that. Tell the patient. They don't want to suck on that. They don't want to bother the sutures. They want it to just sit there and get a wonderful clot in it. and heal for a period of time until that has had a chance to clot and grow initial osteoblastic activity in and around the grafting material. Excuse me. That grafting material is basically a scaffold, just like a scaffold on a building, and the bone grows in around it. Some of those stay and never resorb. Others do not stay and do basically resorb out. Instruct the patient what to do, and then we're going to talk about antibiotics. That's a controversial point. I usually deliver them, but many do not. You're going to talk about that in a minute. Antibiotics. If you're going to do antibiotics, when would you do them? I'm going to show you uncomplicated, as that infers, and then we're going to go to complicated. Let's go back to uncomplicated. What's an uncomplicated situation? Well, the uncomplicated situation is you've taken the tooth out, you haven't particularly broken the bone, you have near primary closure, you have no infection that you can see, and if you're going to deliver antibiotic, then this is a fairly common situation. Amoxicillin, 1 gram, 1 hour pre-op, then 500 milligrams 6 hours later. In other words, just 2 shots at them. Now, many of you are going to disagree, and you're in different countries where antibiotics have different doses and people think differently, so there must be 100 ways to do this. Pick the one you like. If they're penicillin allergenic, used to be erythromycin, didn't it? But that's been pretty well put aside because of gastric challenges, and clindamycin 600 milligrams 1 hour pre-op, then 300 milligrams 6 hours later. So there are some easily used materials that would provide for you a good assurance that there would be no infection caused by the oral sewer in which you're working, and you know that as well as I. In fact, it seems absurd to me to look in a mouth just loaded with billions of organisms and talk sterile field. Are you kidding? If that person has some organisms that are going to cause a problem, they're going to cause a problem. So I like to cover them. What is well, there's an uncomplicated case. Now let's look next at a complicated case. Where are we going now? And what is a complicated case? Acute infection, a very large socket, sinus involvement, which you occasionally find on root tips on molars, going right into the sinus, membrane placement. Membrane's kind of a foreign body. Prolonged traumatic extraction. You did 20 minutes, took 20 minutes on something you thought would be 5 minutes. A diabetic, an immunocompromised person, or anything that appears to you that might cause some kind of infection. What are we talking about? It's the same drug, amoxicillin, 1 hour pre-op, then 500 milligrams TID for 3 to 5 days. So it's just prolonged. Go back. I'm going back. You see, here we just gave them 2. We gave them 1 gram and then 500 milligrams. On this one, we've given them 1 gram pre-op and then 3 to 5 days TID. Penicillin allergic, clindamycin 600 milligrams. Go back. We got 600 milligrams there too, but here we're going to continue again 300 milligrams for 3 to 5 days. Now that's simple. Is that mandatory? Absolutely not. There are those who probably are sitting there criticizing me right now. People who would not give antibiotic, and we're being encouraged not to give antibiotic. You know that. The hospital that I deal with quite commonly has sent out an ultimatum recently saying don't deliver the antibiotic unless you feel it's absolutely necessary. But then you go into the research. You look at the meta-analysis and you find if the antibiotic is given, the chances of a graft taking, or let's go even more into implants, if the implant is placed without antibiotic, there is a little more chance of lack of integration and infection. You have to make your own decision. I can't tell you what to do. You're the doctor. This woman had practically every negative thing you can imagine done in her mouth. She's about 80 years of age, very affluent lady. I wish all my patients were that affluent. She had over on this side, she had implants placed by someone, and they had placed, believe it or not, they had placed nickel alloys as abutments and nickel chrome crowns. I had to go in and cut slots in these, take them off. It took me 20 minutes, and I'm a pretty fast operator, even to take that off. So there was the first problem, nickel. She had these placed at an angle that I can't even believe. Someone had placed them. You can see the angle. Look, they're going the reverse angle. They could have gone straight down, and unbelievable mess. There was one tooth that had a cracked root and extreme pain. So in this particular case, we're going to walk right through this and let you see what I've done using some socket grafting. Let's look. I have what I call an exploratory appointment. If you look back, I don't know what's under that. I usually tell a patient, we're going to have you in the end of a day. I'll keep a dental assistant or two with me, send the rest home. We will have a temporary prepared for you. We will take off everything on that upper arch. When you leave, you will have a provisional restoration on that will look decent. It won't be wonderful, but it'll be about as good as what you have there. And you're going to wear that until I have a chance to really totally evaluate which teeth can remain and which cannot remain, which need endo, which need to be removed, and so forth. So this is the exploratory appointment. I've built up teeth. You can see we've taken off the old restorations over here. This tooth is a cracked tooth, extremely painful. I can't even touch that without causing her to jump. So that's got to come out. But look how thin that bone must be there. I'll bet that bone. I've done a lot of cone beams. We do cone beam on standard implant placement, and I'll bet that bone is only a ½ millimeter thick. Even a normal extraction with a forceps can break that bone off. Now I'll be dead, because I need to keep that bone, and I need to keep it in such a manner that it will that I have the same level as the bone over here. We can do it. In this particular case, I went in, did a little. Now you could do laser or electrosurgery here to get that to be about the same length as this over here. It needs a little electrosurgery as well, or laser, whichever you use. Electrosurgery is literally 10 times faster and many times less expensive. If you go to the literature, electrosurgery and laser in many areas of medicine, including OBGYN, including ENT, they're fighting just like we are in dentistry as to which one's the best. They both work. They're cars and they're automobiles. So there's what I'm seeing. Can I get that tooth out without breaking that very, very thin buccal bone off? Can I do that? And the answer is yes, but let's look at how we're going to do that. Let's look at atraumatic extractions. If you don't have these instruments, for crying out loud, just get them. There are many companies that have proximators. Okay? Proximators are very thin instruments. You're going to look at them. Carl Shoemaker is one. Brasler has them. There are numerous companies. Salvin has them. A proximator is a very thin little, almost like an elevator. We're going to look at it. Here's a conventional elevator. By the way, I'm going to have questions a little bit later in the program, so I'll open that up. Take a look at this huge, that's a standard elevator. It looks like it's a snowplow. Here's a luxator. The luxator came from veterinary dentistry. You know, I was the one who brought it into the profession. Very thin blade. I was doing some dog research, and I could not get the teeth out. I asked my colleagues, veterinaries, what do they use to get dog teeth out with? They're just like rock. And they told me about luxator. And the JS was the first one to bring them in. They're from everybody now, also the same group of people. And those used properly, I'll tell you what properly is in a minute, take the tooth out without breaking the bone. Subsequently, another company came along and said, why don't we use an even thinner blade? Look how thin that baby is. Don't elevate with that. You'll break it right off. You got to use this billy club to elevate. So you have the largest one, useless in what I'm talking about. You have the luxator, which is extremely well proven now for 20 years, and you have the proximator, which is Johnny come lately from Carl Shoemaker or others. So get one or either of those. I'm going back now. There are many shapes. I would suggest a straight one and a slightly angled one. They're not inexpensive. Therefore, get something. You don't need these various angles. I seldom would use those angles with these things, but get at least a straight one. There's a straight one, and a slightly angled one, so you can get into the posterior. So what do you do with it? It's relatively simple. Look at the difference in size there. This will break the bone. This will basically loosen the contiguous tooth. This goes between the bone and the tooth. Has nothing to do with the adjacent tooth. This levers on the adjacent tooth. So let's put this in mesial. I'm saying something very important if you haven't used these. Mesial and distal. Don't even think about facial and lingual. There's another instrument much like those, a little thicker, but this is a brand new instrument, Grip Deep Extracting Forceps from Miltex, that will allow you to go down mesial distal again on a tooth such as we're going to take out. Grip Deep Forceps from Miltex. They have a lot of innovative instruments like that. Okay, look, we did it. How did we do it? The proximator went in mesial and push, jiggle between the bone and the tooth. Don't play with this tooth. Push, jiggle, push, jiggle, push, jiggle. And then go over here. Push, jiggle, push, jiggle. And what will happen when I say jiggle? Back and forth, back and forth, back and forth. Soon you'll see the tooth move. You'll break the periodontal ligament. And as you continue to do that, that tooth will virtually pop out and hit you in the head. You'll be amazed. Now, how was I taught to do this? Let's say, oh geez, that was totally in the dark ages, but let's go back there for a minute. I was taught if I could not get the tooth out, or if I broke it off at the bone line, that I was supposed to take the buccal bone off. How stupid is that? I'm serious, how stupid is that? If I leave that little thin piece of bone and I fill this with something up to the bone level, I just said something important. Don't come to the gum level. You're going to the bone level, which is probably in this case 2 to 3 millimeters apical from this soft tissue level. In this case, see, someone has taken these teeth out, and again, they have not grafted well. If you take a tooth out and you do not graft the socket, you're looking at what happens. If I left that socket ungrafted, that's the way it would look very shortly. Keep looking. How much do you need? These are averages from many, many different grafting materials. A small socket, what's that? That's a lateral incisor, maybe a small premolar, a half to 1 cc or 250 milligrams. The specific gravity of these grafts is all about the same. A medium, that would be a large bicuspid or first molar, second molar, 1 to 2 cc's or 500 milligrams to 1 gram. These are just good guides for you because you're going to buy those by volume. And if you're doing a whole quadrant, which would seldom be the case for me, here's my thought, and you may not agree with it at all. If this tooth I'm extracting is in the smile zone, that's pretty easy. Just have the patient hold a mirror up 1.5 feet from their face and have them smile as big as they can, and then show them what teeth show. It's pretty obvious what teeth show. Most people will show upper, first premolars, second premolars, and the mesial buccal of the first molar. Now, some of you are in Europe, you don't smile as much. I don't say that in any derogatory way. That's a fact. In America, people smile like the village idiot most of the time. So if you get somebody who is a big smiler, you better do this right or you'll have a dent. I had a referral recently from a periodontist, and he had not grafted on a premolar area, and then he had placed an implant. Someone had placed a crown, and the crown was apically extended about 2 millimeters apical to where the normal gingival line was in the premolar area. The woman did not like that. I took a tooth out, grafted it, put an implant in, and it ended up not degenerating more apical in the contiguous teeth. Now I had a problem. She said, how come this other one has this recession? She didn't say that. How come it has that display of a longer crown? What are you going to say? Anything I would say would indict the other dentist. He was too dumb to graft the socket, for crying out loud. Graft the socket. Just do it. Let's keep moving. Now here's the product we're going to show tonight, BioPlant, and I could show you a dozen of them. Kerr is basically brought this webinar present, and therefore I'm going to emphasize this one. It is the one I use the most. This is polymethyl methacrylate spheres. They're porous. They have on their surface a polyhema, hydroxyethyl methacrylate. What's hema? Hema is a wetting agent. And these little porosities in these balls will soak in the osteoblastic activity because of the polyhema that's there. They also have calcium hydroxide on them. They come in a couple sizes. And these little balls do not resorb. They are polymethyl methacrylate. What the heck is that? That's denture resin. And you're saying, how in the world can you do that? Now this would be what kind of a graft out of those four? What is this? What do you call this? Can you remember what we called this? This is an alloplast. This is a synthetic alloplast. All right, let's keep looking at it. There's that hole. Now they have a little nozzle on this now. This better than the thing I'm showing you there, but this was such a big hole I just used that right out of the bile. The bile plant is placed into the socket after you have stimulated some blood to come out of the socket. You do not want the blood out of the gum. You want it to come out of the socket because that has the bone generative concept that we need to make that grow into these little balls. So let it bleed for a few seconds. Make sure the blood is not coming from the gingival tissue, and place this into the socket and push it in. How hard is that? Now I'm going to suck that up into these little balls. Watch what happens. If I suck it up into the balls and let it clot for I'd say 30 seconds, maybe a minute, it'll get gelatinous. Now there's nothing hard here. You keep watching. Now stick it, keep moving, and now I've just pushed it in. You can see the little balls have gone here and there and everywhere. I'm now going to blot that and watch what happens. I'm going to put some gel foam over the top of it, but keep looking first. Gel foam, what is it? Gel foam's the least expensive of these agents that will somewhat block those balls from falling out. They'll fall out if you don't hold them in for at least a little while. This is water insoluble. It is purified pig skin, held in place with moderate pressure, absorbed completely, liquefies in 2 to 5 days. 4 to 6 weeks for full absorption. It's I tend to remember $10. It's around $9 a sponge, so you can't go too wrong with that. What are we going to do with it? Take the chunk. Now look at the balls. The balls are at the bone level. They're not at the gum level. They're at the bone level. So let's take this and cut a little circle a little bigger than the actual hole that we're looking at. Okay, and put it into the hole. You see it's a little bigger. It's probably twice as big. And you know how soft and mushy that gets very rapidly. So as you put it in there, it'll start to degenerate the second you put it in. I've stuffed it in the hole. How am I going to leave it like that? No, they'll suck that out in 10 minutes. So I'm going to place a couple little cross stitches. It's a little tight. That'll loosen up very shortly. Now let's review what we did. We have that at the bone level, not the gum level. This is the foam that's gone over the top. The sutures here are Vicryl. I don't care what kind of suture you use. I prefer Vicryl, as most general surgeons do. There are some who are using chromic gut in periodontics. That somehow got into perio heavily. I don't have any problem with chromic gut. The only thing I'm not using anymore is black silk. Black silk's black. Black silk doesn't dissolve. This stuff dissolves over a period of 2 to 3 weeks. So there's a little summary of what we've done. Let it bleed. Does this look hard? I hope not. Let it bleed. Let's suck the blood up into it. And the gel foam goes over the top. And suture it. Okay, I'm ready to make it temporary. Right? And now the temporary has previously been made by whom? It's been made by are dental assistants. I am a real delegator, and I know some of you are in countries where you don't delegate. I was in one of the European countries recently, and I kept talking about dental assistants. Finally, some guy came up and wised me up, said, "We don't have dental assistants here." And I said, "Huh? How the heck do you work? If I had no dental assistants, I would be about half as productive as I am." Anyway, dental assistants have cut about 1/2 millimeter off a diagnostic cast, right to where the red ends here. And then they have made, from a previous impression of her old bridge, they have made a polymethyl methacrylate external layer, and I'll show you the brand name of that. What's this blue? I prepped deeper than they cut. In other words, I want to put this in the mouth, this red thing, and have it just fall in place. Many of you are buying temporaries. In the U.S., one of the companies that has probably the most market there is Glidewell out of California. For in American dollars, $35 per unit, and they're made out of the country, but on the other hand, they're excellent, and they are made of polymethyl methacrylate. My problem with that is somebody else has cut the cast, and they don't know where the heck I'm going to cut it, and therefore I have to ream them out. This exact case I'm showing you, which was made with Vita Zeta, you may not know that. Vita Zeta is one of the most kind, low exotherm, lower. All of these polymethyls have high exotherm, but Vita Zeta has a moderate exotherm, relatively easy to use with colors you will not believe. Most of you are used to using, in America at least, Jet, J-E-T, and Jet's got a few miserable colors that don't match any shade guide. They're okay. They have a high exotherm. Vita Zeta is going to cost you a little more money. It's matched to the old Vita shade guide, not the master. And this will provide for you a very polishable external surface. Many of the things you're buying from companies, from laboratories, are made of denture teeth. Therefore, they're almost always Bucky Beaver. They're sticking out a little further than I like to see them. Now, there's this shell my dental assistants have made out of Vita Zeta, cold curing polymethyl methacrylate from Vidant. You see how thin that is? Now, I've prepped far deeper than that. This is just a barely thin membrane. And I'm going to go back several shots here, right there. So this red is what you're seeing on that previous slide. What's the blue? That's ethyl methacrylate. Most of us are using, well, one of the big bridges I did today. We did a fairly long span with bis-acryl, which 3MSP dominates the market there in America with Protemp 3. And on a bridge that had a lot of interspersed either implants or natural teeth, that's fine. If I've got something like this one, I would prefer methyl as the external, lined with ethyl in the mouth. Exotherm's a little high, but just take it off and on, off and on. So ethyl will go inside of that. And I assure you I did not touch that. It came right from my dental assistants having made that. I put it in, and it went right on down. In other words, they had not prepped this so deeply that I had to ream it out. That's my major challenge with many of them from the lab. Is this wonderfully beautiful? No, I don't really want it very beautiful. Why? If I make it too good, I could make that temporary better than the final result's going to look. I pretty well guarantee you. So I want about a B. I don't want an A, and I prefer not a C. So that's untouched at that point. It's going to be lined with polyethyl methacrylate. What the heck is that diaper on there? The diaper is good old household aluminum foil. And that aluminum foil, why have I got that on there? The aluminum foil is there because I do not want this ethyl methacrylate to go down into that socket. Can you see what might happen? If that ethyl methacrylate goes down in there, I've got poor healing. I can't guarantee what's going to happen. It might even, when I take it off, pull out the graft I just put in. So that's a chunk of household aluminum foil placed over the ridge. And now we're going to use some polyethyl, well, it is ethyl methacrylate. It becomes polyethyl methacrylate. And you know those brand names as well as I do. Snap is one of them. Trim is one of them. trim is probably the most popular one in America. And I'm sorry I don't have the major brand names in all the countries you're in. I do have them, but it would be unlikely that I should announce them here. And now that's allowed to go to a putty consistency. A little drip of monomer is placed into the methyl methacrylate shell. The teeth, listening carefully, I'm on something important. The teeth are Vaseline, because if I want to have those so they will not be permeable, and then the thing is placed down into place, and you end up basically with that. The ethyl and methyl are totally compatible, they chemically bond, and I have a provisional. And there was the thing in place. Now, granted, it's pretty monotone. That's fine. I don't have a major problem with that. She's going to have something better shortly. That's with the ethyl inside. Here comes the fixed prosthesis back. The thing we're getting to here in a minute is she's going to have a ridge left there. With bioplant, now I have no marriage to Kerr. I love Kerr, but I love Dentsply and 3M and the rest of them. They're all part of our team. But this product from Kerr has almost no shrinkage of the ridge. I wish I really had good data on that. It's well over 90% of the ridge is retained. Can I put an implant into it, or could I put it around an implant that was superficially not very adequate? It was a nice cream cone. The answer is yes, I could. However, it does not integrate as fast as an example, the foundation that I mentioned to you just minutes ago. The foundation in 10 weeks has healed adequately that I can put an implant in it. With bioplant, I prefer, and now Kirsten, one of the Kerr people, is listening. Kirsten, if you don't like what I'm saying right now, you bring up a question. I like to wait longer, 9 months or a year, before I'm going to put an implant into a socket that I have grafted with bioplant. I can go a lot faster with other materials, but my major use for this is ridge preservation for a subsequent fixed prosthesis. And I'm open for criticism there. What is this? Implant, implant, implant. Tooth, 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 tooth. Now what's that? That's a bottomed out APM stern gold rest between the natural teeth and the 3 implants. And where are we going from here? There is the thing. You're seeing implants. That's the lower. That's the lower. And I've done an upside down male female. Some of you don't even know what I'm talking about there. In other words, that will not show, because this woman's very aesthetically oriented. She would not like to display that. On the upper, it makes no difference. She can't see that unless she's in some pornographic movie. She's not looking at that. Down here, when she opens her mouth, you would see that if I didn't make it upside down. Okay, so there's the lower. Here's the upside down male-female here. And you can pretty well see the natural teeth and the implants. Now they were in the mouth. Now, important to you is, what did it do to that grafted site? Well, let's look. Now, before I show you, it's kind of shocking. This woman wanted pure toilet bowl white. I mean, A1M1 was hardly white enough for her. So if you don't like this white, you Europeans like orange and brown and green and red. Americans tend to like one color. I was in Los Angeles for several years on a church mission, and I only had one shade on the shade guide, toilet bowl. There you go. Okay, you look now. Look at the ridge here, and with the exception of that little piece of tissue, it's still there. This is 4 years. 4 years. And we're still functional there without any shrinkage. That I've tried to take you through a very simple situation of grafting. Now let's look at the radiographic orientation to this. Here it was at the time of the graft. This is the very patient we just looked at. And you'll see, well, it's a little ratty looking right here. I think it's pretty interesting to look 3 years later. Let's see if we can follow it. It's hard to follow, but you can see the bioplant has not dissolved away. The bone has grown into the bioplant. But I think what's interesting is it appears, it's a little different angle, but it appears that it's more homogeneous there than it was when I put the dumb stuff in. Now that gives you some example of where in a crown and bridge situation it's advantageous to preserve that ridge. There she is, and that is white, baby. She's white. There are some numbers that you Americans can use, and pardon me, you Europeans and Asians and so forth, as I give them these numbers. A number that you may use for grafting, you may not get paid for it. It's called bone replacement graft at time of extraction. Bone replacement graft at time of extraction. That ADA code number is 7953. If you're using a membrane, and I don't call what we did there, I don't call that a membrane, but if you were using a true membrane, that is called membrane, and that is 4266 or 4267. Now you would add the extraction costs to that. I don't like to tell you what the fee is in America. I don't like this fee, and I don't have the fee that high. But the average ADA amount, and it also comes from Atlanta Dental Consultants, Tom Lamoli, is around $500. I'm a little over half that, but I'm just giving you some averages so that you can work out. I would much rather have that woman happy with her bridge, and I'll get her on the other end. I'll get her on the crowns. But in the meantime, I'm not going to have this ridge preservation be a major expense for her. It changed her life. I absolutely agree that this simple procedure makes for a really nice situation. There are those codes I just gave you. And now it's around $500 plus the extraction fee. Am I going there? No, I'm not there. I'm a little over half that, but you have to make your own judgment. Here's my summary, and then I'll open up for a few questions for a few minutes. I'm going to read that because I really believe it. When educated to the value of the socket grafting, few patients will refuse it. All I have to do is show them a couple of pictures, like the pictures I started out with nearly an hour ago. You get yourself a few pictures like that. You show them. They can't turn it down unless they're stupider than a rock. They're going to want it. Use simple grafting materials. If I'm not planning an implant, I guarantee I'll be a bioplant. If I'm planning an implant, I'd probably have a little faster material. And inexpensive membranes, usually not needed for some materials, like the one we just looked at, and your fee can be reduced and still be acceptable from a financial standpoint for you. I think it's time to do that. Now let's open it up for some questions for just a minute. Oh, by the way, I forgot to remember I had that in there. There's a copy of our current practical clinical courses catalog available to you at the website I gave you, pccdental.com, and that'll have about 100 and some odd videos in it, and all kinds of courses. In fact, if you're out of school, up to 5 years out of school, we have half fee for any course I give, and there are those websites again. Now, how about a couple of questions? I wish we had more time, but these things are short. Okay. I see Sammy. Well, there's Justin Scott. Justin Scott, can you use gel foam with BioOS? Oh, if I've got nearly total closure, surgical closure, yes. If I have not got closure, there are other membranes that would be better for you, and membranes like I mentioned them to you before: Biomend, BioGlide, or Cytoplast. But now you're talking some money, no question at all. Here's another one. In case of a traumatic extraction, I guess I better go to this question and answer mode. Where are we here? In case of a traumatic extraction has been done, so what is the, I don't have the complete question there. What type of membrane do I prefer? I prefer a resorbable membrane like I just mentioned to you. The basically we have numerous membranes that could be used there. The short-acting membranes are relatively inexpensive. Remember them? Colla plug, Colla tape. They're both excellent. If you get this CR report May 2010, there will be a whole page of brand names that you compare. Can you use gel foam with BIOS? I just said I would prefer probably not to. If you crack the buckle plate, would you attempt to maintain? And I'm not getting the rest of the question. I guess it doesn't show up. If I crack the buckle plate, would you attempt? I imagine he's saying that would I use the keep the piece of bone? And no, I would not. I'd grind it up and put it into the socket hole. Sammy, from your experience, when to use or not use a membrane? If you get primary closure, a membrane still is not good, guaranteed. I'm sorry, if you have primary closure, the membrane's not going to stop that aggressive movement of soft tissue. As I mentioned to you, it's about 500 microns per day. That's a half millimeter per day. And the bone only goes at 50, a tenth of that. So if you have one of these lower cost ones like Colla plug or Colla tape, you can put that over the coronal surface and have a reasonable acceptability with materials like BIOS and so forth. Do you need primary closure with the BioPlant and gel foam? No. Have you ever tried Regeniform? We have not evaluated Regeniform. Okay, what type of membrane do I prefer? I prefer one that will resorb. In case, no, that one doesn't have the whole question. Can you use gel foam with BIOS? That one I've just answered. I'm getting repeats of these questions. Okay, other questions. I'm going to the top of the list of questions now. Let's see what I can pick out here. Any histology on the BioPlant? Oh my goodness, yes. BioPlant was originally brought to the market by Arthur Ashman, a real leader in implant dentistry. He's probably about my age. He's got a few years on him. And Arthur, when I first heard this, I thought, Arthur, this won't work. It's denture resin. And then I, knowing quite a bit of the chemistry of it, thought, well, it's got polyheme on it. It's going to suck juice in there and therefore suck into it the osteoblasts. And yes, it works, I can guarantee you. What graft to, well, I keep getting this to glitch. What graft to prefer if one has to implant? I wish I had another couple hours with you. One I did just recently, it was on an upper first premolar. Obviously that has two roots on it, and the roots are in the wrong place. They're facial and they're lingual, and I want the implant right down the center, don't I? I put into that one foundation. I let it go 12 weeks, and what happened in 12 weeks? The bone was almost rock. However, with that product, J. Merita, that's cow skin, I did not need a membrane. I could put over the top of it gel foam, and I sutured it over the top. However, you lose, I'm going to guess, because I don't know any research on this, I'm going to lose about 20% of that bone on the coronal surface. With BioPlant, I would have had to wait for months and before I put the implant in, but I would not have lost as much bone. In that case, it didn't matter. Let's see, how to graft in a multi-rooted tooth. I just said that. When you're grafting in a multi-rooted tooth, I know many would say just go ahead and put the implant in and then graft all around it. That I do that occasionally, but it's not my preference. I would far rather have some good solid bone there before I put in the implant so that I can see there is bone there. I'm not in any big hurry. Most of these people have had missing teeth for a long time. They're wearing a partial denture or something. Is smoking a problem when it comes to grafting? Yeah, it kills you. First of all, it kills you. And secondly, in almost every study that has ever been done on smoking and biology, it has been negative, and that relates to implant placement, grafting, and the whole business. So if someone is smoking, will I still do implants? Yes. Will I still do grafting? Yes, but only with a lot of informed consent, because the chances of it not working are pretty severe. Can we mix BioPlant with patient's blood on glass? You could. That makes a mess, but you could do that. Hydroxylapatite versus BioPlant. Hydroxylapatite is, again, well, there are various forms of it, but a lot of it is insoluble, as you know. I had one case about 25 years ago where an oral surgeon had put hydroxylapatite in, and he had perforated one of the fascial spaces that went down in the neck of the person, and you could see little balls clear down their navel. And I'm exaggerating, but at least down to the clavicle. It works, but I prefer the polymethyl methacrylate. Okay, looks like time is up. And where are we? Bioplant. This guy, Jerry Kirk, has just heard that bioplant materials are poor grafting materials. Well, you have opinions from various people. I have been a significant proponent of mini implants. I've done hundreds of them. I've lost 5 over 10 years. Yet I hear from many people, oh, they don't work, they don't work, they don't work. Until they've done 100, don't talk to me about it. We've done a lot of grafting with this. Looks like I've got to quit. Well, by the way, there's a good question just came up. How does medical grade calcium sulfate work? It works very well, but it does dissolve out relatively rapidly. You put it in, it dissolves out, and it's miserable to work with because it's so slimy. Well, again, I want to thank Kerr for sponsoring this thing. I have, I hope, been broad spectrum in what I've said. There are many products that can work. Please go to our website and pull out that whole page of products. And we'd welcome you to come to Utah to our courses. We have hands-on courses here that are at AGD mastership level. Many of them are on implants, they're on grafting, they're on mini implants, standard implants, and they're on all areas of restorative. Thank you much. It's been great to be with you. Appreciate it. And have a good day or night, whatever it is where you are. Thank you.